Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium. Thank you.
Welcome. My name is Dr. Sheldon Mark Feldman. I'm speaking to you from Montefiore Medical Center, Albert Einstein Cancer Center in Bronx, New York. So good morning, good afternoon, good evening, depending on what time zone that you're in. So again, I'll be speaking with you through this LE&RN Online Symposium about the prevention of breast cancer-related lymphedema. My current role is Chief of Division of Breast Surgery and Breast Surgical Oncology and Professor of Surgery at Montefiore Medical Center. I'm also the Director of Breast Cancer Services. This series is supported by the generous support of, as you see listed, the following sponsors. And this is an important disclaimer that this information is provided to you for use in consultation with your healthcare professional, and it certainly is not meant to take the place of healthcare or services you may need. I have some disclosures. I have received research funding from Avelis, Invuity, and Atossa, and I'm a consultant and speaker for Invuity and Zeiss. I have not received any financial support for providing this webinar for you today, so I have no conflicts related to today's presentation. So I want to give you an overview of today's presentation. Basically, we'll be talking about general topic of breast cancer-related lymphedema, discussing quality of life issues that patients experience related to axillary surgery, the rationale and options that we have to minimize axillary surgery, clinical strategies to reduce breast cancer-related lymphedema, including axillary reverse mapping and lymphatic venous anastomosis or Lympha procedure, as you'll learn more about, and talk about patient education surveillance to identify early extremity volume change, and then we'll have time for questions at the end. So this is a picture of my sister Fern, who tragically lost her life to breast cancer when she was 37. She was diagnosed at age 35. I was a surgical resident at the time and was involved in her care, and her experience in this tragedy taught me a great deal about the patient's perspective and the suffering that patients go through as part of our breast cancer treatment, and it certainly has motivated me to be involved in taking care of patients with breast cancer and helping to advance the field and helping to minimize the morbidity related to the treatments that we use. So good news is that cancer mortality has been declining in the United States. As you can see from these graphs, we've made significant progress, and this is certainly due to multiple improvements in diagnosis and treatment. This shows that a lot of the benefit of our reduction in mortality relates to earlier diagnosis with screening and the use of adjuvant therapy. So as you can see from these curves, in patients who are not screened or who do not receive any adjuvant therapy or treatment in addition to surgery, do not have a good outcome and have the highest death rate. With screening and adjuvant therapy only, it's better, but certainly the best group is a combination of the two. So we're getting quite successful at treating patients with breast cancer. So in terms of symptoms, diagnosis, and philosophy, so the good news is that over 80% of our patients with breast cancer are now asymptomatic when they're diagnosed. In other words, the woman who feels a lump in her breast, or the doctor may feel a lump on routine physical exam, or a woman has a mammogram or a screening sonogram or MRI, which finds a new breast cancer. So that's most often a very early diagnosis. The way we make the diagnosis is using a needle biopsy of the lump. We don't do surgery to make the diagnosis, but we use a type of needle biopsy which allows the diagnosis to be made. And from that needle biopsy, we get a tremendous amount of information, not just about whether this is cancer or not, but the type of cancer, its biological behavior, what the best treatment options will be for the patient. So as you'll see later, breast cancer is not one disease, and there are multiple different subtypes of breast cancer, and we learn a great deal about that for the particular patient based upon that needle biopsy. So philosophically, we want to strive for minimally effective treatment, not maximally tolerated treatment. So we don't want to overtreat patients. We want to treat patients with enough modalities that they are cured of their disease without leaving them with many side effects related to our treatment. So the goal is to be cured while avoiding the side effects. And since most patients are asymptomatic from their breast cancer when they're diagnosed, you cannot make that better. In other words, you cannot improve on being asymptomatic from a disease. So the onus on physicians who take care of breast cancer patients is to not leave patients with many side effects and symptoms that are related to the treatment that we provide for patients. So the benefits, to talk about the sequelae of breast cancer treatment. So we know that our treatments are quite effective. However, many cancer survivors are at risk for developing both physiological and psychological late effects of cancer treatment, which can lead to premature mortality and morbidity, and even more so, compromise their quality of life. So psychological symptoms, anxiety, depression, fatigue, sleep difficulties, loss of self-esteem, and then physiological changes, including pain, numbness, cognitive impairment, weight gain, loss of sexual interest, menopause, peripheral neuropathy. And of these, lymphedema is a major, major quality of life issue, and that's why we're talking about this today. So what are the kind of symptoms that patients can experience after axillary lymph node surgery? Well, pain, definitely numbness, weakness of the arm. There can be limitations in the range of motion of the arm. There can be fluid collections in the armpit area. We call that a seroma. There can be cording of the axilla, which we call axillary web syndrome, which are actually lymphatic channels which are blocked from the surgery. There can be swelling of the arm, and that's what we're going to be speaking about today specifically, is about lymphedema.
You can see it.
So what is lymphedema? So this is actually the definition of lymphedema from the Lymphatic Research and Education Network website, who is sponsoring this webinar. So lymphedema is a chronic lymphatic disease that results in disfiguring swelling in one or more parts of the body. It can be hereditary primary lymphedema or can occur after a surgical procedure. So specifically today, we're going to be talking about in breast cancer, for example. It can appear in the arm or on the same side as the cancer after lymph nodes are removed from the armpit area for cancer staging. So from the patient's point of view, lymphedema worse than mastectomy. I fear lymphedema more than cancer. And lymphedema reminds me that I have cancer every day. So you can see from a psychological, emotional, beyond the physical, that this is quite a significant impact on quality of life. So we know about lymphedema that it is chronic, is long-term, often requires lifelong treatment. It is very common, but is often underreported, and it greatly affects quality of life, and it has financial burdens in terms of health care and for patients in terms of their employability. The scope is very large. We have over 3 million breast cancer survivors in the United States, and there'll be over 4 million by 2024. Worldwide, almost 2 million women are diagnosed annually. And the lymphedema rates, as you see, for sentinel node biopsy, which I'll explain to you more in detail later, is the lowest, 5 to 7%. Axillary node dissection a bit higher. Axillary radiation, 10 to 15%. And the highest group are those who have axillary lymph node dissections and radiation, where it can be up to 40%. Of course, the lowest rates of lymphedema will be in patients who do not have axillary lymph node surgery, and we'll talk about that in more detail. So as you can see, in terms of healthcare costs, patients who experience lymphedema have significantly higher healthcare charges related to their breast cancer treatment versus women who do not. And then in terms of impact of lymphedema on work and career after breast cancer, you can see the significant impact in terms of loss of days at work, etc., depending on the severity of the lymphedema, with it being the worst for patients with severe lymphedema. So very important and from both the financial and from a work and quality of life point of view. So it is the major morbidity of breast cancer treatment, impacts on life, quality of life and survivorship, often chronic, and it can often be poorly controlled. And patients who are poorly controlled outside of experiencing the swelling and discomfort can also develop very serious infections. They can develop cellulitis and lymphangitis, which actually can be life-threatening. And there's an unusual type of cancer called lymphangiosarcoma, which can occur as a secondary malignancy. The risk factors are the number of lymph nodes removed, patients who are heavier, who have a body mass index of over 30, patients who've experienced radiation, certain types of chemotherapy. Taxol, for example, increases the risk of lymphedema, elderly age, and patients who start at baseline with a limited range of motion. The incidence in the high-risk group can be as high as 40%. So here's the big problem. A lot of awareness about lymphedema is not there. When I go to meetings and speak with lymphedema therapists, the biggest problem they face is that the surgeons in their community often don't feel like there's a lymphedema problem. Their patients don't get lymphedema. So we got to stop burying our heads in the sand and really deal with this problem face on. So of course, just as our beloved goalie here in New York, Henrik Lundqvist, stopping this goal, prevention is the goal. So let's talk about lymph node removal, and is it important? Well, for many years we thought that removing cancerous lymph nodes from the armpit area actually improved overall survival. Well, lots of studies have now shown that's not true. It is important to not leave cancerous lymph nodes in the armpit area because local recurrences or axillary recurrences or persistence of disease can be very morbid and patients can have many side effects. But in terms of survival, there is no benefit. It is important to achieve local regional control. As I'll talk a little more about, it's very important in staging, and I'll explain to you a little bit more what that is, but cancer is generally staged from early to advanced based upon this TNM classification. It can guide systemic therapy, although this is becoming less of an issue because the biology of the cancer is much more important. And again, I'll explain more about that and the complications that we've talked about in terms of lymphedema, pain, shoulder mobility, and nerve injury. So the rationale for clinical staging is that it really affects the prognosis and defines the prognosis, and it guides appropriate treatment. It allows guidelines for treatment and allows us to communicate about different groups of patients, particularly as it relates to clinical trials. So this graph shows the outcome of survival depending on stage. So stage 0 breast cancer is really non-invasive breast cancer or ductal carcinoma in situ, and typically in that situation, lymph node removal is not part of the evaluation. Then you can see for the different stages, stage 1, 2, 3, and 4, very different prognosis and survival depending on the stage. So historically, anatomical stage has been the key. So T means tumor size, N is whether there are lymph nodes that are bad, and M is whether there are metastases or spread elsewhere in the body. So now the 8th edition recently came out this past year, and now this is what we call a prognostic stage. So it's actually based more, not just on the size of the tumor and whether lymph nodes have cancer, but actually the biology of the cancer, what we call biomarkers. And important ones are the estrogen receptor, progesterone receptor, and the HER2/neu, also the tumor grade or how the cells look under the microscope. And then we can do a deeper dive into the tumor to look at what we call the genomics of the tumor, so that we really have an understanding of the prognosis, less and less based upon the size of the tumor and whether there are bad lymph nodes, and more based upon the actual biology of the tumor. The prognostic stage, as I mentioned, it really incorporates tumor biology, and there are different ways of scoring this, both before and after chemotherapy, which I'll explain to you in more detail. So this is probably the most important slide for this introduction for you to understand, is that breast cancer is not one disease. There are different subtypes, or we call phenotypes, of breast cancer. The most serious, worst prognosis are the basal-like breast cancers, or also called triple negative. So these patients, unless the tumors are very, very small, almost 100% of the time will be recommended to receive chemotherapy as part of their treatment. The HER2/neu overexpressing tumors, also in the past, very, very poor prognosis, But now with specific targeted therapy, anti-HER2 new therapy, they have a very good prognosis. And again, for these patients, almost always they'll be recommended to receive chemotherapy as part of their treatment. And then these are more favorable types, which are estrogen sensitive, which are quite common. Systemic therapy is recommended for them, but potentially not chemotherapy and more hormonal therapy. So what I'm getting at is that for most breast cancers, at that time of that initial needle biopsy, when the diagnosis is made, we really know a lot about what is the overall treatment plan, not just in terms of local therapy, but in terms of systemic therapy. So this was stated in a very elegant way by Dr. Blake Cady, who's a leading breast surgeon this past century in the United States. And this was, I think, a very important quote. Lymph node metastases, or cancer in lymph nodes, they're indicators, not governors of survival. In other words, they tell us about the biology of the disease. They tell us about what treatments will be required, but they don't really govern the survival. So biology is the king, selection of cases or patients is the queen. The technical details of surgical procedures, meaning if we remove lymph nodes, how many lymph nodes we remove, whether we do a mastectomy or lumpectomy, are princes and princesses of the realm who frequently try to overthrow the powerful forces of the king and queen, usually to no long-term avail, although with some apparent temporary victories. So I think that says a lot. So a big advance was in 1998 when this study was published in the New England Journal of Medicine, the sentinel node in breast cancer. I was fortunate to be one of the co-authors of this important study, which really changed the game so that most patients no longer had to have all their lymph nodes removed or have an axillary dissection. So the sentinel node hypothesis is that a breast lymphatic drainage goes to a specific or signal or sentinel node. A negative sentinel node, or a sentinel node that doesn't have cancer, that predicts with a high accuracy that the other lymph nodes are also without cancer, so no need to remove them. And this significantly reduces morbidity of axillary staging. So this is the concept. If there's the cancer, so we know by injecting dyes into the breast that we can identify the first lymph node where the cancer cells must travel to if they spread. If we remove this lymph node and it's free of cancer, then we know from our studies that all these other lymph nodes are free, so no need to remove all these nodes. Up until 1998, every patient with breast cancer, pretty much all the lymph nodes were removed. Once we proved sentinel node was a safe, effective approach, we could do much less with surgery. So again, the gatekeeper concept that the cancer, these are the lymphatics from the breast, would have to go through this lymph node first before there could be any spread to other lymph nodes. The way this is done is a radioactive dye can be injected into the breast, or a blue dye. We use these specialized Geiger counters called gamma probes, which allow us during the surgery to identify the most important lymph node. So this is, and I apologize for some graphic imagery, but I really want to make the point for teaching. So this just shows the difference between, this is a sentinel node resection, removing a sentinel node, which is typically 1 or 2 lymph nodes, and this is an axillary lymph node dissection. So a huge difference. So up until 20 years ago, all patients had this done, and now most patients have this done. And then if the lymph node shows cancer, we'll talk about some patients do still need to have additional lymph nodes removed, and there are different strategies to reduce morbidity related to that. And again, just to show a little bit of the anatomy of the axilla. So if this is the breast, you know, the axilla is the armpit area. These are the chest wall muscles. These are the arteries, nerves, and veins that run in that area. When we do lymph node removal, we preserve the arteries and veins and as many of the nerves as we can. The lymph nodes are at different levels. The lowest level, the lymph node level 1, which is typically where the sentinel node is, and this is usually where the lymph node removal is done for sentinel node biopsy. And as you can see in green here, these are the lymphatic blood vessels coming from the RN. I'm going to spend a little more time on that later, that will drain into the lymph nodes. So when we do procedures to try to save lymph nodes, we're saving these lymphatics and as many of these lymph nodes as possible. So sentinel node biopsy is a major improvement, and it does replace lymph node dissection for patients with healthy lymph nodes and markedly reduces breast cancer-related lymphedema to 5 to 7%. So a very important study, which I'm going to spend a little time on, was this ACOSOG Z11 trial. So this was a trial looking at patients who had sentinel nodes that actually had cancer. In one group, the additional lymph nodes were removed, and in another group, they were not removed. So it was a group of patients who were having lumpectomy or breast conservation surgery. And what we learned, all these patients did receive, or the vast majority received radiation and systemic therapy. And what we did learn is that 27% of the patients had additional lymph nodes that were not removed, but there was no difference in survival, and I'll show you the data. So what that did was allow us, for patients who had limited removal of their sentinel nodes, up to 2 lymph nodes involved, to not then proceed with doing a complete lymph node removal. And although this study has been published for a while, still there are many sites around the country where patients continue to have lymph node dissection done just because there hasn't been full uptake of the results of this study. But it's important to realize that this is now should be standard of care. Now, it has not yet been proven that it's safe to avoid lymph node dissection in patients who are having mastectomy versus lumpectomy. Since when we do a mastectomy, if there's cancer in the sentinel node, it's actually the number of lymph nodes that are involved with cancer which determine the benefit of whether patients would receive post-mastectomy radiation. So positive sentinel node lumpectomy, maybe no lymph node dissection. Positive sentinel node mastectomy, likely a lymph node dissection. So what that means is that there's a difference in the likelihood of lymph node surgery, whether patients choose to have a lumpectomy or mastectomy, and I'm going to spend a little more time on this. This just shows graphically the results of the ACOSOG Z11 trial, which really showed overall survival and disease-free survival at 10 years of follow-up now, that there is no difference. And as you can see, actually perhaps slightly reduced in the lymph node dissection group. So this data is solid. So patients have to understand, if they choose a mastectomy over lumpectomy, they may be increasing the likelihood that they will undergo a lymph node dissection and be at increased risk for developing lymphedema. And this is not a conversation that happens all that often, so patients really need to understand this point. And it's very relevant, more so than ever, since actually mastectomy rates have been increasing among patients who are eligible for breast conservation surgery or lumpectomy. So this was a review from this time period, as you can see, of over 1 million patients, of whom 35.5% had mastectomy. It was a significant increase in mastectomy rates in patients who are eligible for breast conservation over the past 8 years. Greatest increase in mastectomy rates in patients with early stage disease, and the rate of bilateral mastectomy has been increasing as well. So again, patients who have a mastectomy, if their lymph node shows cancer, may be increasing the odds of their developing lymphedema. Why is this happening? Well, better reconstructive techniques, which is fantastic for patients who need to have mastectomies, immediate reconstruction, peace of mind for patients that they don't need to have any more mammograms or checkups, and patients are more proactive. And there's a lot of online social media information which may advocate for this. And breast MRI, many of us believe, increases the risk of patients actually having mastectomies, because sometimes MRIs have false positives. Patients get frightened through the experience, then go on to opt to have a mastectomy. But actually, there's no data that breast cancer-specific survival is better for mastectomy, and there is data that actually suggests it may be worse, but I don't have time to dwell on that today. So how do we evaluate the lymph nodes in the axilla? Well, if someone has a swollen lymph node, it can be felt, and then it's pretty easy to just put a needle in that swollen lymph node to confirm whether there's cancer or not. But more and more we use ultrasound, and these are examples of the appearance of, this is a normal lymph node and abnormal lymph nodes with ultrasound. So here's a lymph node that's really been replaced by tumor. Here you can see what we call the cortex is thickened, so that's a sign of cancer. So we can diagnose cancer in lymph nodes very often by doing an ultrasound and a needle biopsy, and that turns out to be very important. Now, when we treat breast cancer, there are 2 components to the treatment. So Dr. Halstead, who is a pioneer of radical mastectomy many years ago, thought that the more radical surgery we did on the breast area, the better the survival would be. Dr. Fisher said, well, no, early breast cancer often can spread microscopically through the body, so unless we treat the whole body systemically with medication, we're not going to change the outcome. And in fact, both are true. Largely, for some patients with very early disease, they can certainly be cured with local surgery alone, particularly patients with ductal carcinoma in situ, stage 0, or very favorable stage 1 breast cancer. But the vast majority of patients, what they can die from is that microscopic cancer cells have spread through the body, and unless we treat those cells, the patients can relapse later. So essentially all patients with breast cancer require local therapy, which can be surgery with lumpectomy or radiation, lymph node evaluation, and possible radiation. Essentially, all patients with invasive cancer will require systemic therapy. This could be with anti-estrogen medication and or chemotherapy to treat cancer cells that may have spread to organs outside of the breast. So how do we decide the sequence of treatment decision? Which should go first? And this is really the fundamental question we ask for almost all patients. So we can base this decision, as I alluded to earlier, based upon the subtype of the cancer, the size of the tumor, if there's lymph node involvement, and many patients, more than ever now, as medications are getting more and more effective, benefit from systemic therapy prior to surgery. We call this neoadjuvant. Adjuvant means treatment after surgery. Neoadjuvant means before. So why do we consider medicine before surgery? Well, if we know what medicine they're going to get, the results of surgery are not going to change that for most patients. So the tumor can get smaller if we give medical therapy first. It can even disappear. We call that a complete response. So it's possible to remove less breast tissue, avoid mastectomy for many patients, and also maintain a more normal appearance to the breast. Also, germane to this conversation today is that cancer-containing axillary lymph nodes can become cancer-free, avoiding an axillary lymph node dissection. So a cancerous lymph node can then be rendered cancer-free, and we do sentinel node biopsies in patients after chemotherapy so that they can be spared axillary lymph node dissection. And of course, we can also assess how well the medicine works when we give chemotherapy prior to surgery, because with the lump we can see will disappear. If we remove all the cancer surgically and then give medication, well, there's no way to actually assess whether the medicine is working or not. So this is just a chart. It's a little complicated, but it shows what we call the complete pathological response in the lymph nodes based upon the type of cancer the patient had by receiving chemotherapy before surgery. And here you can see certain subtypes: estrogen and progesterone receptor negative, HER2 negative, or triple negative cancers. And look at this, HER2 positive cancers. So complete response rates in the lymph nodes as high as this one series, which is extraordinary, 79%, 70%, but a very high percentage of these patients will have complete response in their lymph nodes. So do we need to do sentinel node biopsy for every patient? Well, I think it's emerging more and more that it's probably not necessary even to do a sentinel node biopsy. So this is an older study by Martinelli and colleagues from 2005. And this was not a huge study, but basically over 200 patients in this age group. And you see one group had a lymph node dissection and the other had no axillary surgery. They all received radiation and tamoxifen, which is an anti-estrogen medication. And as you can see, at 5 years in terms of recurrence in the axilla, there was essentially no difference. This is a trial which has now completed accrual, which is showing where we're heading with this, called the SOUND trial. So sentinel node biopsy versus no axillary surgery in patients with a preoperative or negative preoperative axillary ultrasound, patients tumors less than 2 centimeters, any age, patients having lumpectomies. So they're randomized. If one group of the patients gets sentinel node biopsy done, the other no axillary surgery. And we're waiting for the results of this, but many of us predict that there'll be no difference in outcome for these two groups of patients. So how do we decide about axillary surgery? The patients really need to ask their doctor to explain how the results of sentinel node biopsy or axillary lymph node dissection will influence the decision about their subsequent systemic medical therapy or radiation. And for many patients, the nodal information is no longer required. So therefore, it has become routine in the past for lymph node surgery to be part of breast cancer surgery, but more and more we must question that practice as really being beneficial. And of course, avoiding axillary surgery will significantly reduce lymphedema risk, although there is still some risk of lymphedema from axillary radiation. So how about the surgical approaches to reduce arm morbidity? Well, as we talked about, no axillary lymph node removal unless it's really required. It is important that axillary node surgery be performed by an experienced breast surgeon. Technique is important to limit the number of lymph nodes removed. So sentinel node biopsy should be the most minimal number of lymph nodes removed. In the big trials, it's 2.3 lymph nodes. So rarely should additional lymph nodes than that be removed. And also in the technique of doing it, since the lymph nodes are very near sensory nerves to the upper arm, these nerves can be injured during the surgery. So it's very important for the surgeon to preserve these nerves. There's often transient numbness just from the dissection, but it should improve with time. And then we're now I'm going to talk about methods to identify and preserve or reconstruct the lymphatic vessels during surgery. And there are 2 different approaches I want to share with you. One is axillary reverse mapping. The other is called the Lympho procedure, or lymphatic microsurgical preventive healing approach, which actually recreates an anastomosis or connection between lymphatics and branches of the vein that go to the arm, which in the past were just tied off or ligated. So again, just to show a little bit of the lymphatic anatomy of the area. So this is the breast, these are the lymphatic channels. So here you can see these are lymphatic blood vessels coming from the arm, and what happens is they join these lymph nodes here. So one of the things we've wondered, these lymph nodes drain both the arm and the breast. So if someone has a scratch on their arm, for example, like a cat scratch, they can get a big swollen lymph node here. If someone has a melanoma of the skin of their arm, they can get a big swollen lymph node here that contains cancer. If someone has a breast cancer, cancer can spread to the lymph nodes here. Can we tell the difference between the lymph nodes that are related to the breast and those that are related to the arm? And the answer is that we can. And this is a technique called axillary reverse mapping. And this was popularized by my colleague, Dr. Suzanne Klimberg, who's now in the University of Texas. Basically, axillary reverse mapping means injecting a special blue dye into the arm to map the lymph nodes that are blue that are related to the arm, and then we use a radioactive dye that injects into the site of the tumor in the breast, which drains to the sentinel node, which is the one that's related to the breast cancer. So again, just to show this and go through that again, the blue dye is injected into the upper arm, and the lymph nodes that are related to the arm and the lymphatics are turned blue. So for the breast surgeon, we can say, well, stop. Don't remove those lymph nodes, because they're the ones that if we remove will increase the chance of developing lymphedema. And the radioactive lymph nodes, which we find with a gamma detector, which is identified by injecting radioisotope dye into the breast, those are the sentinel nodes, and those are the important ones to check for the prognosis of the breast cancer. So this is an example, blue dye injected here, and the blue lymphatics in the axilla. So here's an example of this lymph node was hot, so that's the sentinel node from the breast. And this is a blue lymph node, which is an arm lymph node. You can see how close together they are. So if a surgeon doesn't use careful technique, inadvertently this blue node could be removed as a sentinel node, and that could increase the patient's chance of developing lymphedema. This is, for example, in about 5% of patients, that blue node and radioactive node are the same, so there is crossover. So in this setting, what's been done is that the sentinel node is removed, but the lymphatic blood vessels are then reconnected by sewing the two ends together. So another technique that I've been very involved with is called the Lymph procedure, and this is lymphatic venous anastomosis. So we're reconnecting the lymphatics to a branch of the vein during the surgery. So this is not done after when someone develops lymphedema. This is a preventative procedure, first described by a Russian surgeon in 1989 and really popularized by a group from Genoa, Professors Bucardo. There's Professor Bucardo and Campisi. I was fortunate enough to visit them and learn their technique. But they described their results in 2011 initially, a small group, 46 patients, who had complete lymph node dissection done, and only one of the lymph patients experienced lymphedema. So they had an incidence of lymphedema of 4% versus 30% in the control group. I became involved with this work when I was at Columbia, and then I opened a trial there, which I'll explain to you. And then follow-up data in 2014 from the Genoa group showed, again, 96% of their lymph patients were free of lymphedema. This is a paper that my group and I published in 2015. Again, our experience with lymphatic microsurgical preventive healing approach, or Lympha, for primary prevention of lymphedema. And really the way this works, and I'll show in a little more detail some of these cartoons, is that the blue dye is injected, the lymphatic vessels are identified, and then after the lymph nodes are removed, there'll be a basically connection done between the lymphatics into a branch of the axillary vein. So this is showing it here. This is blue is the arm vein. The green are the lymphatics from the arm, and here you can see they've been reconnected or sewn into a branch. Now, one of the things, this is a vein, so their venous return, like people get bulging veins, you'll see sometimes. So there must be a competent valve. This valve closes, so when the lymph is draining into this area, there's no blood flowing back, so it doesn't overwhelm the lymph. And then when patients take a deep breath, these valves open and the lymph fluid sucks back into the venous circulation. This is showing this in more detail. Multiple lymphatic channels can be put into a single vein. So this shows intraoperatively. Again, I apologize if this is offending to some people, just the graphic images, but it's important to see. This is a blue lymphatic going into a branch of the axillary vein. This is what the axilla looks like during surgery when it's opened. And this is a more detail, one of my patients from who had a lymph procedure. So the arm would be here. You see this is a lymphatic channel, lymphatic vessel, which has now been connected or sewn into a branch of this main axillary vein so that the lymph flow will go back to where it's supposed to. And it's done in the operating room with a microscope. It does add about 45 minutes. There are no complications related to the procedure. So it's technically somewhat demanding, but very, very successful. So this is my very first patient who agreed. So she had faith in me and in God. She's a nun. She's lovely. And as you can see, being the first in any clinical trial of an unproven technique does take some faith. But she has a high BMI. She's heavy. She has severe arthritis. She ambulates with a walker. And her big concern when she learned she had breast cancer and that she needed to have a mastectomy and to have lymph nodes removed was that she might develop lymphedema. And fortunately, now with almost 6 years of follow-up, she has developed no lymphedema and she's doing quite well. The way we can tell that the lymphatic channels are open, this is something called a lymphscintigram. It's an injection of a radioactive dye, which indicates injected into the hand. This would be the arm, and this is showing the isotope draining normally on both sides, which implies that there is normal lymphatic drainage for this patient. So the results with this have been quite satisfying. I've continued this work here at Montefiore, and we've now had quite good success with a total of 43 patients who've undergone a successful procedure. In the early days, some of the patients could not have it done successfully because there was a learning curve. These are patients who were very high risk for lymphedema. They had elevated BMI with average almost 30, advanced disease. Many of them had mastectomy. Many of them had many positive nodes. This is the average number of lymph nodes that were removed. And a follow-up of 30 months, 7% of the patients experienced breast cancer-related lymphedema versus 31% in historical controls. And then of the 10 patients who could not have the lymph procedure performed, actually half of them, or 50%, developed lymphedema. So this shows a significant benefit. So there are prospective trials now being designed to further this work. So the last thing I wanted to talk to you about is an important panel that we convened at the American Society of Breast Surgeons in 2017. Dr. Sarah McLaughlin from Mayo Clinic and myself and many breast cancer specialists and lymphedema specialists were involved in this work. And it became a multidisciplinary expert panel looking at considerations for clinicians in the diagnosis, prevention, and treatment of breast cancer-related lymphedema. And I want to highlight some of these findings. So these were some of the panel recommendations. So some of them sound pretty simple, but they're important. Surgeons should admit and accept that lymphedema risks exist, and they must educate themselves and their patients about these risks at preoperative and follow-up visits. And education should continue into survivorship and should be incorporated into survivorship care plans. So patients need to understand if they're going to have lymph node surgery that they're at risk for lymphedema. They need to understand what the warning signs are, what pain, swelling, heaviness, all those things can mean, that surveillance is important. We have to educate patients. We need multiple languages. We need this to be translated, self-care. There's a lot to do to really get the word out and to really have patients understand and be able to diagnose changes in their arm early on. So number 2 is establishing a surveillance plan, because early diagnosis can lead to early treatment and increases the likelihood for limited disease burden. So when we look at, basically stage 0, it's really not apparent, up to stage 3 lymphedema. So there's a progression. So if we have a baseline assessment, which is good, and then surgery happens, lymph node removal, and then, as patients begin to get symptomatic, discomfort, heaviness, and then by the time you can measure with a tape measure or they have clinical signs, it's pretty late. So we really want to find lymphedema or volume change or preclinical lymphedema as early as possible. This was a study that was done a while ago, which showed by actually identifying patients who began to have volume change and then treating them with compression therapy that you could normalize their arm volume over a relatively short period of time. So early diagnosis definitely improves outcome. So recommendation number 3 was that baseline and follow-up measurements of the arms is very, very important. There were different techniques which I'll talk about, but the key is that a baseline measurement should be performed so that sequentially when patients come for their follow-ups, the measurements can be repeated, and if there's any interval increase in volume, then we can react to that with a simple support stocking. So the way lymphedema can be diagnosed, here you can see patient-reported symptoms, usually not early. There's something called a pyrometer, which can be used and which is very, very accurate, but it's expensive and it has a large footprint, so it's not used that frequently. We used to use this volume displacement, which is a big cylinder full of water, and that you'd put the arm in and you would measure how much volume was displaced, but it's not very practical. Tape measurements are done very, very frequently. They're not terribly reproducible. They're very time-consuming. And we've really moved towards most centers using bioimpedance spectroscopy to really identify this. I'm going to spend a little more time on that. So basically, this is a technique where a low current, electrical current, is passed through the body, and basically, if there's more volume, it changes the speed of the current being transmitted through the body, or the impedance, or what we call resistance. And electrodes are placed to achieve this. This has been a somewhat cumbersome thing to do, and there's a newer technique now, which is the SOZO platform, which allows BIS to be done in a very non-invasive and very, very streamlined way for busy clinics so that we can be sure we do these measurements on patients. And as you can see, the patient is standing, with the shoes and stockings off. There's an electrode here, here, and on the hands, and we get very rapid, reproducible results with this. So as we've spent a lot of time during this presentation, clinicians should practice personalized medicine strategies to minimize axillary surgery and question the routine use of post-mastectomy or nodal radiation, axillary node surgery itself, and to use the biological features of the cancer to minimize lymph node surgery. We talked also about recognizing that the mechanistic theory is probably too simple. There's a lot more going on than just removing lymph nodes. So there are definitely genetic differences and inflammatory pathways which are being investigated to reduce lymphedema risk. And this is emerging science. It's very important. And then there's been discussion about, what behaviors can cause lymphedema. So can you have your blood pressure taken or have an IV on the side where lymph nodes have been removed? And really, there's very little evidence to support these precautions. Many patients feel safest by being cautious from that point of view, which certainly is a good thing to do. But intravenous venipuncture, blood pressure measurements flying without stockings lifting, really seem to be fine. Uncertainty about sauna and the heat of that. So generally, being careful with this is good, but this absolute recommendation to avoid all these activities really is not supported. And then exercise is supported. So for many years, patients were disallowed from exercising if they had lymph nodes removed because of the fear of it developing lymphedema. And all the studies really have shown that resistance and aerobic exercise is safe. Obviously, working with a trainer or not overstraining or stressing is extremely important. And then, as we've talked about, incorporating preventive surgical strategies, including axillary reverse mapping and lympha, and cooperative trials which are in development to further evaluate these techniques is important. So we can minimize lymphedema risk by doing less axillary surgery, which include obviously sentinel node biopsy, pre-op chemotherapy for node-positive patients to make them node negative potentially, no sentinel node biopsy at all if it will not affect systemic therapy, preserve arm nodes with mapping techniques, specifically axillary reverse mapping, if patients require full axillary dissection because they have extensive residual disease or extensive disease in the axilla, then lymphatic venous bypass is a great option for them. Monitoring patients for preclinical volume increase with bioimpedance spectroscopy is very, very useful. Educating patients and making sure that they're aware of the potential lymphedema risk. Physical therapists are extremely helpful in helping patients resume normal range of motion and to reduce their lymphedema risk. So de-escalating axillary therapy has been very helpful. As we know, there are multiple factors involved, and a very careful patient-specific approach to restricting axillary therapy will reduce morbidity and improve quality of life for patients. in those patients who still need axillary dissections using the newer techniques to reduce morbidity. So with that, I thank you for your attention, and we will move on to questions if there are any. So let me just get our screen back so we can get to that. So thank you. I have a question from Catherine Jansen, and let me repeat the question. Are you going to discuss about the association of trauma on the on-risk arm, blood draws, blood pressure, IV? So, you know, I mentioned briefly in the presentation that I think the evidence really does not support being overly vigilant about this. I mean, I always tell patients that if they have the choice, if they're going to have their blood pressure taken, or they need to have an IV, or they're going to have a blood draw. So generally, being proactive. But I think what happens is patients get very frightened that if they have a blood test done, that they're going to wind up with lymphedema, and oh my God, what can happen here? I think creates so much anxiety and trauma in patients that I think, you know, and there's certainly no evidence that this is true. One of the common ones as well is whether patients should wear a compression sleeve when they fly, and there've actually been some good studies which really show no benefit. That being said, I have patients who just really worry about it, and they feel much more comfortable if they wear a compression sleeve when they fly, and there's certainly no downside to it. So I think it's one of those where common sense is really the key. I mean, the patients who really are very physically active, who want to work out, who do weightlifting, I think it is important that they have a supervised program so that they don't strain the arm and they don't wind up with a problem. So, so I think those are very practical, very important questions. I think, you know, if I'm going to make one overarching final comment related to this topic, which is that, you know, we just have to begin to educate patients and physicians both that many of us who grew up in the era where every patient had all their lymph nodes removed, and then we made big progress and moved to sentinel node biopsy, which of course was a tremendous advance, we're now continuing to de-escalate axillary surgery, and that we've learned for many patients with actually the most serious breast cancers, particularly those with triple negative and HER2 positive cancers, that the medical therapy, the targeted medical therapies work so well that the additional benefit or information that we get by removing lymph nodes really doesn't benefit patients in a meaningful way. So I think based upon that, we're able to do less, and you know, the most important thing and the most important maneuver in preventing lymphedema is going to be to avoid axillary surgery. And the point I made earlier as well about avoiding mastectomy unless it's really indicated, because it is true right now that if a woman has a mastectomy and she has a bad lymph node and she hasn't received chemotherapy prior to surgery, her chance of having a lymph node dissection and increasing her risk to lymphedema is going to be much, much higher. So having a full understanding of that and it shouldn't make the decision necessarily one way or another to whether to have a mastectomy or not, but I think it should be important that that be factored into the discussion. So I think with that, we've run out of time, and I'm sure there'll be a mechanism through the website or through the webinar if there are more questions that I can respond in the future. And I thank you very much for your attention, and have a great day.